She is a physician specializing in breast and gynecologic surgery while a medical student. She developed a lifelong passion for women's health and went on to complete a fellowship in breast surgical oncology at USC, studying under Dr. Melvin Silverstein. Combining state-of-the-art breast surgical care with a holistic approach to breast cancer and gynecologic care, Dr. Kelley strives to bring the very best in women's health care to every single one of her patients. So I'm very, very privileged to introduce Dr. Kelley to you today. Thank you.
Thank you, everyone. And I'm just thrilled to be here today. This is a wonderful opportunity for us to address a topic that's important to all of us. Our goal today is to get into some of the questions that you've probably asked yourselves or asked each other over a lunch just like this one, when you've read something about breast cancer in the news or had a friend or neighbor be diagnosed. These are questions that come up for all of us when we face this disease that's very common in our communities. We want to also kind of open up some other questions, some new questions for you. How can you keep yourself healthy? How can you keep your friends and loved ones healthy? Where are things going? What do we know? What are we going to learn? And what's coming next? One question that I probably will not be able to answer for you today, at least not on one slide, is that question that we all ask when this comes up, which is why? Right? Why did Susan get breast cancer and Jane did not? Why can we cure Susan's breast cancer, but her neighbor Linda has a breast cancer that she has to live with for a little while? You know, what's going on here that's making this happen? These are million-dollar questions, right? If I could answer this right here today, we could all go home happy, right? Thousands of labs around the country, dozens of journals are filled with studies, all trying to answer this one question. So why is this question so complicated? Because cancer is complicated, okay? Our cells are amazing things. They are little tiny, incredibly intricate, highly regulated little machines that communicate, they grow, they divide, they cooperate, they make all of the chemicals and enzymes and building blocks that make us who we are. There is a lot going on in there. Think for a second about all of the growth and division of cells, all the organization of cells that has to happen to make an 8-pound baby turn into a 25-pound toddler and a 50-pound fifth grader. All of that growth and change and organization is happening on the cellular level. So it's really complicated in there. When the cell is dividing is the time that it's the most vulnerable. Our DNA has to open, unzip, and be exposed to the environment. So cell division is a time when the cell is really, really vulnerable. And that's important because that's the time that things are gonna happen that can lead to changes in the DNA that can lead us down the road to cancer. Ultimately, cancer happens because our cells are human too. And they're human just like us, which means they can make mistakes. Over millennia of evolution, our cells have developed multiple lines of defense against these kinds of mistakes and are busily correcting themselves all the time. As we're encountering things in the environment, age, wear and tear, our cells are busily correcting all these problems. So when a cancer occurs, you know that multiple different lines of defense have been breached. And that implies that there's been more than one mistake accumulated over a period of time. Right? So cancer is almost never one event. One thing almost never causes one cancer in one person. And that's why it's difficult to answer this big question about why. We can start to get at some of the risk factors, we can start to get at the causalities, but there's usually not one big why. Who here has had a bike accident? Anybody? Bike accident? Bike accident? How about a car accident? Fender bender? Anybody? All right. Think about that event for a second. Think about all the things that had to go wrong at once, at that particular moment, to make that event happen. The light had to stay yellow a little bit too long. Driver was distracted just a fraction of a second too long. Maybe the brake pads were a little bit worn, and then bam, right? So you want to think about cancer as being like these car accidents. A lot of things have to go wrong over a period of time to make that happen. Sorry, I'm going to adjust this. So today when we talk about what causes breast cancer, what the risk factors are, I want you to keep that image of the car accident in your mind. All cancers are complicated and multifactorial events. So when we're talking about one risk factor, remember that that's just the yellow light. And then we're talking about another risk factor, maybe that's the cell phone that the driver is busily texting on, right? No one event is going to be the answer for everything. But even though we basically know what contributes to automobile accidents, there's still 25,000 cancer or motor vehicle-related accidents, deaths in this country every year. So the fact that we understand what's going on doesn't necessarily mean that we can always prevent it. So that's going to be one of the ways that we think about risk factors. Remember about risk factors, if you're texting at the wheel, doesn't mean you're necessarily going to have an accident that day, right? Maybe you're going to get lucky. But if you're somebody who leaves their cell phone in the trunk when you drive, you're going to be less likely over time to get an automobile accident. So that's the way you want to think about risk factors as we go along. So with that image in our mind, we're going to turn to our discussion. And I want to start out today by talking about breast cancer risk in Marin, because of course that's really the thing that sticks out in our minds when we think about it. People feel that this is a community that's at increased risk, and often people don't know why that is. We're going to get into that. You've all heard that the risk is increased. You may not understand when or why that happened, so I want to go back and talk about the history for just a second. There was a large increase in the rate of breast cancer cases in this county in the late 80s going into the early 90s. From an epidemiologic perspective, this really did look like an epidemic. It was very different from what was going on in other counties in California and around the country. This really got everybody's attention. It generated a lot of research, and it generated a lot of advocacy in the community. So even though things are changing, we've made a lot of progress, the legacy of that time and the fear that was generated is a big part of the fabric of our community. Anybody get the Zero Breast Cancer newsletter in the mail recently? All right. So there's a graph right on the front of the Zero Breast Cancer newsletter now showing that rates of breast cancer in Marin have just now dipped under the California average. Right? So things are changing, and we're going to talk about some of the reasons why. All right, so this visual is old data. This is 1997 data, but it puts in visual context why this became such an issue. You can see at the bottom of the purple line, this is the breast cancer rate in Marin. This is a raw incidence number, so it's the number of cases per 100,000 people in the population, greater than the US white population, the US black population, and every other country listed. All right. As a quick sidebar, as we go through our slides, I'm going to talk a little bit at times about statistics. We're going to try to be really clear about what the numbers I'm giving you mean. What I've found in my practice is that one of the things that people find the most confusing and misleading is misinterpretation of statistics. So it's really important, I think, to understand not just what a number can tell us, but also what it can't tell us, and to understand where data come from so that we don't get confused by statistics. So if I wax a little bit technical about statistics, I'm really just trying to help us be very clear about what these numbers mean. So again, this is 1997 data, so this data is over 15 years old, and things are changing quite a lot, but this sort of frames our discussion. This slide shows us data from that same period of time, a little bit closer to home. So this is Marin County rates compared to every other county in California. This is age-adjusted incidence, so it only includes those women who are in the age range potentially affected. And you can see, again, this is the height of the difference between Marin and other counties in California. It was a really big difference. So when we ask this question, why are breast cancer rates in Marin so high? we have to sort of parse out what is it that we're really asking? How can we answer a question like this? We have to understand what's causing a disease in a population. And a population is a complicated thing. People come and go. Not everyone's lived here forever. Some people are moving in, people are moving out. Risk factor reporting can be variable. Right? When you ask people about what they eat and drink, for example, sometimes the answers you get are maybe not quite what's really going on, just as an example. Risk factors can also interact with one another. And a really important thing when you think about statistics is this principle that association is not necessarily causation. So what does that mean? Great example of that is socioeconomic status. So socioeconomic status in multiple studies, multiple countries around the world is associated with higher rates of breast cancer. More affluent nations have higher rates of breast cancer. More affluent women within those countries are more likely to have breast cancer than less well-off women. Now, we know that the amount of money in your investment accounts or your GDP is not giving you breast cancer, right? So there must be something else going on. Socioeconomic status must be functioning as a proxy for other things that do create more possibilities for DNA damage. Things like diet, activity, other medical problems, longevity, cultural factors, ethnicity, all of those things. So that's a great example of something that's an association where there's not direct causality. So you have to be pretty careful about those things. So what we want to know, is living in Marin County all by itself an independent risk factor? And is it causation or is it association? Is it really the geography? Is it the water? Is it air from the Richmond refinery? Or is it something that's going on here that's an association? Okay. So in the late 90s and early 2000s, the scientific and advocacy communities here got together and designed a couple of studies to answer this question on an epidemiologic level. There are two main studies, the Marin Adolescent Risk Factor Study and the Marin Women Study. The Adolescent Risk Factor Study was a case control study, so took 300 plus cases of breast cancer matched with 300 controls. So this is more on the individual level. Let's get down in the weeds about what's happening to individual women who are getting and not getting breast cancer and compare them to each other. They looked at family history, reproductive risk factors, all kinds of demographic data, how long they'd lived in Marin, what age they were when they moved to Marin, all of those things. And there were only two differences that were statistically significant between these groups. One was being born into an affluent family, being well-to-do before the age of 21. And the other was alcohol intake, over 2 drinks a day. Otherwise, the groups were completely identical. So that was their first piece of kind of individual level data. The Marin Women Study is a much bigger, more epidemiologic scale study. And they're looking at more than 14,000 questionnaires that were filled out by women at the time of their screening mammogram. Who here participated in the Marin Women Study? Right, so lots of people, right? So data from many, many women in the community is part of that study. Many women contributed saliva samples as well. So we're using those things to look at this first piece of the epidemiologic data, which we'll talk about, and then a lot of ongoing studies. So let's look at the data from the Marin Women Study and see what it tells us. So this is data for a 20-year period looking at race and ethnicity. So we know that ethnicity is an independent risk factor for breast cancer. Breast cancer rates are significantly lower in Asian and African American women compared to white women, about 88 per 100,000 versus 155 per 100,000. So big difference in rates. Note, again, when we're talking about statistics, that there are only 260,000 people who live in Marin County. So these are adjusted statistics that basically tell you if there were 100,000 Asian and Pacific Islander women who lived in this country, how many of them would get breast cancer compared to those who actually are living here. So the reason that this is relevant to us is that the population in Marin skews towards these higher risk ethnicities. 72% of people who live in Marin are Caucasian white ethnicity, 15% are Hispanic, 6% are Asian. And as a sidebar, Ashkenazi Jewish women who are at significantly increased lifetime risk of breast cancer because of some genetic factors are also a much larger part of the population, about 1.2% of the US, 1.8% of the US population, 7.5% of the population here. So already we're starting to see who lives here makes a difference. Body mass index is another of the major known risk factors for breast cancer. Now, this is not a risk factor that's more common in Marin than in other parts of California. In fact, overweight and obesity are a little bit less common in this community compared to other counties in California. But obesity is increasing across the country and has been for the last 30 years. So this is something that's going to factor into breast cancer rates here. In this graph, you can see this data from the Marin Women's Study, which is the little black X's, superimposed with a bunch of other studies that all show you basically the same thing, which is that with rising body mass index, and that's coming this way, there is a rise in the risk of breast cancer. We're going to talk a little bit later on about how diet and exercise specifically can be changed to impact breast cancer risk. So right now we're just going to talk about BMI as a risk factor. So what is BMI? Body mass index is a standardized thing that we use to talk about body fat composition, and it helps to control for things like different body weights, height, things like that, so that we don't, it's better than just weight, because of course people are different heights, different builds, and so on. So it helps to kind of control for some of those things. So why does body mass index make a difference? Well, again, it's complicated. Fat tissue has some very unique characteristics metabolically. First of all, it makes estrogen, and that's an especially important source of estrogen after menopause. When our ovaries stop making estrogen, the source of estrogen in our bodies is coming from enzyme activity in our fatty tissue. So the more fatty tissue a person is carrying around, the more natural estrogens they're making, especially after menopause. Fatty tissue also has chronic low levels of inflammation and higher circulating insulin and insulin-like growth factors. And those are things that are documented both on the lab level and also on the clinical level. Many of those chemicals that are made in fatty tissue, one of their main roles is to promote cell growth. Of course, all this goes back to the way that evolution designed us to survive famine, right? Which was smart at the time and not so helpful now, right? So fatty tissue creates problems for us because it makes our cells want to grow and divide. Another aspect of this is that it does matter not just how much weight people gain, but also when they gain it. So people who gain weight throughout their adult life are actually at increased risk for breast cancer rather than people who start out and remain heavy or start out and remain thin. Right, so change in that over your adult life has a measurable impact. For every 5 kilograms per meter squared, which is 1 point on the BMI scale that you go up, postmenopausal breast cancer risk increases 5%. So that's, again, be a little bit wary of statistics, but that's a very good one. Lots of data to support that. We can also look and see what happens to people who lose a lot of weight. So bariatric or weight loss surgery programs, where people have surgery to help them lose weight, have documented 85% decrease in the risk of breast cancer in their patients who've had successful weight loss. So we see both the way that it works one direction and what happens when you go back the other direction. Next known risk factor that we looked at in the Marin Women's Study, hormone replacement therapy. So medical estrogens have been available to us since the 1950s and were used for a variety of indications. In the 80s, we started to get the idea that maybe women who were going through normal, healthy menopause would benefit from having these estrogens and progesterones circulating around. Women felt great on these therapies. So all of a sudden the idea was maybe this is going to be the fountain of youth. Maybe this is going to delay heart disease. It's going to prevent dementia. It's going to prevent depression. And like a lot of medical treatments, enthusiasm for it got a little bit ahead of the safety data. So by the mid-90s, 25 to 30% of the American population of women were on postmenopausal hormone replacement therapy. And sure enough, people feel generally quite good on this. So a lot of people were happy to take it. But at the same time, studies were going on looking to see if these claims about what postmenopausal estrogen and progesterone were going to do were actually true. Right? Hers, which was released in 1989, and you can see where it's marked on this graph that that study was published, was a big British study looking at the heart health effects of postmenopausal hormone replacement therapy, and essentially showed that it didn't help. In other words, it did not delay the onset of normal cardiovascular disease associated with aging, leading to heart attacks and so on. So it doesn't seem to help. The Women's Health Initiative, which you may all be a little bit more familiar with, was released a few years later. This is a large, ongoing, placebo-controlled study of hormone replacement therapy in this country. The data is still being used to generate new studies, although data collection has stopped. And that looked at not just heart health, but also other outcomes, including things like invasive breast cancer. And it was the WHI that showed us that postmenopausal hormone replacement therapy was associated with an increased risk of invasive breast cancer. After this data came out, as you can see on this graph, women in Marin quit using hormone replacement therapy in huge numbers. It went from more than 25% down to under 10%. Most of those women, or almost 60% of them, reported that they quit because they were concerned about the health effects. So these studies had a big impact on what was really going on clinically. This chart, interestingly, shows you that same graph. This graph at the bottom is the one we were just looking at. Now superimposed underneath the breast cancer rates in Marin, that's the brown line, and in California over that same period of time. And you can see how these track together. So this tells you that there was a really important impact of the fact that so many thousands, and in California millions of women were taking hormone replacement therapy, and when they went off it, fewer of them were getting breast cancer. This looks like a huge change on these graphs. The absolute number of cases that we're looking at here is relatively low. This is a difference of about 20 to 30 cases per year over that period of time. But when you multiply that by all the women in California and all the women in the country, it really did make an enormous difference epidemiologically. Interestingly, the rate of breast cancer in Marin dropped even further than the rate of breast cancer in other parts of California in response to this clinical change. Why was that? So the Women's Health Initiative included two study arms, one where women were getting estrogen and progesterone after menopause, and one where they were getting estrogen only. The only women in that arm were women who'd already had a hysterectomy, because in order to take hormone replacement therapy safely, if you still have your uterus in your body, you have to take progesterone to protect it from developing endometrial cancer. They compared those two arms and noticed that the risk of invasive breast cancer was statistically increased only in the estrogen and progesterone arm. If you then look at the counties in California and look at hysterectomy rates in those counties, you see that the rate is over 50% in some parts of California, whereas in Marin, compared to, along with Santa Cruz and San Francisco counties, the rates are quite low, relatively speaking. There are a lot of reasons that people end up having hysterectomies, but there are also medical and cultural factors in terms of what medical practice is like and what people decide to do. So here the rates are quite low, and that means that percentage-wise, more of the women who were taking postmenopausal hormone replacement therapy in this county were taking both estrogen and progesterone, and that was moving the needle on their collective risk of invasive breast cancer. So that was something that we were able to see looking at this data that we hadn't ever understood before. Alcohol consumption was another factor that we looked at in this study, and we saw a big difference of Marin compared to the rest of California. 76% of women in Marin County reported current alcohol use compared to 50% of women in California. There's very good data about this. There's a big meta-analysis that took more than 50 studies, including more than 60,000 women, looking at the association between alcohol consumption and breast cancer. Women who drank more than three or more drinks a day had 50% greater risk of developing breast cancer, and each additional drink per day increases breast cancer risk by 6 to 7%. So great data to support this. When we put those studies together, we're able to really increase the amount of statistical significance that we can see. The Million Women study in Britain, which is another source of many of the really robust data sets that we have, replicated this. Their estimate of the associated drink per day increase in risk was actually higher at 12%. So the initial data from the Marin Women's study really helped us to understand much more clearly what was going on in Marin and what was driving the high rate of breast cancer. When you add the contributions of these various risk factors that we've talked about up, you can account for a lot of the observed increased risk in Marin County. Not quite all of it, but pretty close. So there's a lot of ongoing research using this data. We're going to talk for a second about what some of the next pieces of research and some of the exciting findings that we're working on right now. So throughout cancer research, in particular how we're using the Marin Women's data, we're interested in understanding how genes interact with environment and then interact with everything that happens to us during our lifetime. So, for example, we know that in general, pregnancy and breastfeeding protect women against breast cancer. But they don't seem to protect everyone against breast cancer. So we're wondering, are there particular aspects or characteristics of pregnancy, age at first pregnancy, duration of breastfeeding, certain aspects of health during pregnancy that might be working for or against us in terms of that kind of protectiveness? This data now is being used to look at how pregnancy characteristics affect breast density. And one of the interesting things that they've discovered is that women who have pregnancy-associated hypertension, which is a common, or high blood pressure, which is a common secondary effect of pregnancy, were shown to have overall lower breast density, and lower breast density decreases breast cancer risk. When they got down even a little bit closer to it, they could see that it wasn't everybody who had pregnancy-induced high blood pressure. It was only people who had a certain genetic characteristic. So that shows us that the way that a woman's genetics are set up to begin with, plus what happens to her in her lifetime, is a major complex of factors that can affect her breast cancer risk over time. What are we going to do with this, right? So in theory, if we understand what's happening on the genetic level that's allowing women to get benefit from an event like pregnancy or breastfeeding, then we might be able to use some kind of vaccination or medication to prime the body to allow that to happen, even if you're not set up for that exact way genetically, or even if you don't have that exact clinical experience. We'd love to be able to give adolescent women a vaccine that fooled their breast into thinking they'd had a pregnancy at 18 and breastfed for 2 years, because that's super protective, but we don't want them to do that, right? So we would love to be able to fool the body into thinking that things like that are happening. Good. So back to our original question. Is living in Marin a risk factor for breast cancer? So geography here is an association, not a causation. Here in this county, there have been over the years and continue to be an increased prevalence of risk factors that contribute to the development of breast cancer. There may also be underlying gene-environment interactions, and there's a lot more for us to learn. So now that we've had a chance to look at the details of breast cancer in Marin, I want us to drill down on practicalities, right? If we've never had breast cancer, we don't want to get it. If we've had breast cancer, we want it to stay away. If we're living with breast cancer, we want it to be as quiet as it can be for as long as it can be. So what do we do to make those outcomes more likely? So first of all, let's just acknowledge that it's really difficult to tell what you should do by reading the news. There's so much that's constantly in the news media, all this noise. It can be really difficult to understand what it all means. I like how my slide editing team stuck me in there between Angie and Joan. Right. So this is a feeling we all probably recognize. Right? You would like to understand what the cancer risk reduction guidelines are, but there are so many of them and they so conflict that it can be very difficult to figure out exactly what you should do. So we're going to frame this by talking about a case. This is a trick that we use in medical talks, keep people going on. This is a woman who could be anyone in this room. Her name is Marina. She's 42. She has a family history of breast cancer in her mother at age 54. Her mother's doing great after treatment. She's 69 years old now. Marina has 2 kids. She had her first child when she was 33 years old, and she breastfed both of her children. She's never had a mammogram because, you know, she has 2 kids, and who has time? So as we go through this case and talk about the different aspects of risk, I'm going to touch on a few things that I think are common misconceptions. Some of these things you may not actually believe, but I think these are very common things that I hear. Right? So one of the things that I hear from people is, if I don't have a family history, then my risk of breast cancer must be low. Not true, unfortunately. Family history is a risk factor. Women who have a family history often fall into a higher risk group, but 80% of women who are diagnosed with breast cancer in this country every year do not have a family history. And well over 50% of women who do have a significant family history never get breast cancer. Right? So it's something that you have to think about in context. So Marina goes to her doctor and asks, what should she do about breast cancer risk? And her doctor tells her the same thing that she tells all of her patients 40 and older, which is go ahead and get screened, get a mammogram. There's been a huge amount of controversy about mammography, so I want to take a look at that pretty closely. Some of the questions that come up around mammography are, should you get a screening mammogram? Is it safe? Does it work? Does it work for everybody? We're going to talk about those things. First of all, yes, you should get a mammogram, right? Mammography has limitations. It is not a perfect test. Perfect tests don't exist, but it is still the very best screening test that we have for mammography. For breast cancer. There are enormous population-based clinical trials looking at the effect of screening mammography on breast cancer-specific mortality. And that's the bottom line, right? That's what we want to know. Does it keep people from dying of breast cancer? And in those studies, there is up to a 30 to 35% breast cancer-specific mortality reduction, right? And mammography is not preventing people from getting breast cancer. It's changing outcomes because we are finding those breast cancers at an earlier stage. We'll skip that. Some of the concerns that come up around safety with mammography have to do with radiation exposure. So I'm going to give you a couple of details about radiation exposure because I think there's a lot of misconceptions about radiation in general. So first of all, what is radiation, right? Radiation is energy, and it comes in lots of different forms. Sunlight is radiation, heat is radiation, all of those things are on the same family. So there's a certain amount of radiation that's potentially dangerous to us. We get exposed to a lot of it. Remember all those defense lines in your cells that are busily helping your DNA be healthy? They're there in part because there's a lot of radiation in our environment. If you get in a plane and fly to New York City, you are exposed to more radiation on that flight because you're above the atmosphere, which usually catches a lot of that radiation, than you get when you get a mammogram. Here's another way to look at it. If you get a mammogram every year between 40 and 80, that's 40 mammograms, you are exposed to less radiation during that entire process than you would get if you showed up in the emergency room with an appendicitis and got one CT scan. All right? So medical radiation is a real issue, but it's also highly relative. You have to be really careful about how you interpret those things. The amount of radiation that you get from exposure from a routine digital screening mammogram on an annual basis is so little that it's essentially the same as the background radiation exposure that your cells know about and are used to and busily fixing all the time. So very, very, very safe thing for us to do. When should you have a mammogram? Most of the major medical organizations continue to recommend starting mammography at age 40. There's some argument about whether mammography is appropriate for women of average risk age 40 to 50. And here's why. there's a relatively low rate of breast cancer in that group. Only about 7% of breast cancers occur before the age of 50. So you're not going to find a lot of breast cancers in that group of women. But if you do, breast cancers in that group are typically more aggressive, they grow faster. If they're not diagnosed, they end up being diagnosed at a later stage, and they're generally more lethal. So we have a better chance of making a difference in individual outcomes in that age group. Unfortunately, we also make higher rates of false positives in women between 40 and 50, and that's because you're less likely to have a breast cancer at that age, and it's also because younger women have more dense breasts, and dense breasts can make mammograms more difficult to interpret. We're going to talk about that a little bit more in a minute. Nonetheless, we do find that the number of quality years life saved by screening women in their 40s, 40 to 50, is enough that there seems to be adequate benefit. Now, there is disagreement between very well-educated and well-intentioned people around this issue, but virtually all the major medical organizations still recommend annual mammographic screening between 40 and 50. So here is Marina's mammogram. This is where we're going to talk about breast density, because while mammography is the best test that we have to screen for breast cancer, it does not work equally well for everyone. She has dense breast tissue, and you can see that the center of her breast is filled with this very thick, white, fibrous material. All breasts are made of fibrous and fatty material. We all have both. Some people have a lot more than one versus the other, and that affects the composition of the breast. This has been in the news because in 2013, a new California law came into effect mandating that breast density information be included in information that's sent out to women with their mammogram report. How many people have gotten one of those really scary, confusing letters? Yeah, right. So this created a lot of consternation and confusion, even though it wasn't new information. It was just going out to the public in a very different way. And that was generated by breast cancer advocates and physicians who were concerned that women were interpreting a normal mammogram as meaning there was no possible way they could have breast cancer, which of course is not the case. So again, mammography is still the best test that we have for screening for virtually all women, including those with dense breasts, but it does have limitations. Dense breasts reduce the sensitivity of mammography. And sensitivity is a number that means if there were 100 women who all came in to get their mammogram on the same day, and they all had a breast cancer that we didn't know about, how many of those breast cancers would we see by a mammogram on that day? So for women who are all the way over on the non-dense side of the spectrum, out of 100 women who had a breast cancer, we would find at least 85 and maybe 90 of them. For women who are all the way on the dense end of the spectrum, that number is somewhere between 45 and 65. That means we're missing between 45 and 65 of those breast cancers too. Right? So that's potentially scary. Right? These are false negative tests. Unfortunately, breast density also increases false positive tests. What's a false positive? Right? False positive is you go in for your mammogram, they give you a call, they say, hey, you got to come back. We see something, you got to come back. Everybody's a callback mammogram, right? Callback mammograms, whoa, those things scare you, right? So you go back in, you have some pictures taken, maybe you have a biopsy. In either way, it turns out not to be cancer. They say you're fine, go home. That's a false positive mammogram. Right? We get those, unfortunately, more frequently in women who have dense breasts as well. So there are real costs to that, right? There's the sleepless nights, there's the financial cost, there's all of those things. But that's the price we pay for the benefit that we're getting. Again, big mortality reduction. So isn't there something better? Here we are in the land of Silicon Valley. Can't we get these guys to make us something better? Right now, there is not. Mammography is still the best tool we have for most women, but there are all kinds of new technologies which we're starting to use. Screening ultrasound is something that we're developing, although it has a lot of limitations. Unfortunately, the false positive rate is very high with screening ultrasound, and the sensitivity is very variable by the operator. In other words, the person who does the screening ultrasound has to be really, really, really good at what they do and very highly trained, or it can get mucked up easily. Screening breast MRI is also potentially very helpful. It's a bigger test to go through, takes longer, more expensive both in terms of how invasive it is and how much the test costs. But it has a very high sensitivity, so it helps us to pick up breast cancers in women who are at high risk. Like screening ultrasound, it has a very high, unacceptably high for many women, false positive rate. Lots and lots and lots of callbacks. So it's recommended only for women who are at increased risk for breast cancer, and in particular for very young women who have dense breasts who are at increased risk. Thermography is not something that we have very much data about. It's not a well-studied test. The studies that we do have suggest that the chance of finding a breast cancer by thermography is no better than a coin flip. So it's not a test that we recommend. There is some new technology coming out around mammography which we're excited about, which is called tomosynthesis. Right? 3D mammography is the way that most people describe this. So 3D mammography is basically as if you were taking a flat mammogram from 10 different angles all the way around the breast. And it improves the pickup rate for breast cancers, particularly in women with dense breasts. Because you're getting 10 mammograms on each breast with each one, it does increase the total amount of radiation exposure, but again, not into a level what we would generally consider worrisome. So for women who have particularly difficult screening mammograms, 3D mammography may be a helpful mechanism. That's the place that we're moving. We're going to have a tomosynthesis machine here in Marin in fairly short order. So that's something that we're very interested in. What this tells you is that we're moving away from a one-size-fits-all approach, which is everybody gets a mammogram and nothing else, and we're starting to tailor some of this imaging to women's particular risk. So let's talk a little bit more about Marina. We've identified a couple of her risk factors. Right? She has a mother who's had breast cancer. She has dense breast tissue. Some of the other risk factors that people think about are things that I want to reassure you about. So some people worry about antiperspirants and deodorants and whether that's something that contributes to breast cancer risk. So is that something that she should quit doing? There's some very good data about that, and it does not show any difference. So looking, these are case control studies, again, women who've had breast cancer compared to controls matched for age and other factors who have not. There's no difference in what kind of products they use, how long they've used them for, and so on. So that's something you can feel very reassured about. There's another thing I hear from folks a lot, cell phone use. I put my cell phone in my bra, I carried my cell phone under my arm. Is that why this happened to me? This is a reasonable question. Right? Cell phones emit non-ionizing radiation, which is a completely different kind of radiation from the kind that causes DNA damage. And there's been several large studies, the best of which is, of course, out of Scandinavia, where many of the best studies come from the Danish Cancer Registry, compared to the Danish cell phone records, because all the Danes are recorded doing everything that they ever do. And we're able to see that there's no association between head and neck cancer rates in particular and cancer rates in general in people compared to their cell phone use, whether they use it at all, plus their cell phone usage. The heavier users are not at any increased risk. So there's some pretty good data to support that this is a safe thing to do. There are no breast cancer specific studies around that, primarily because it's difficult to randomize people to stick their cell phone in their bra. But this is something that I think we can extrapolate the data pretty well. There is a prospective study still going on around this subject in Europe, so we should continue to have some evolving data on that topic. So this table is a little busy, but I want to point out a few things here. These are the risk factors stratified by how much they contribute to the risk. All right, so over here, let's see if this pointer works. We have a couple of things that you can't do anything about. Being female and getting older and living here in the US. So we're all pretty much stuck with those things. Right? And then there's some other things that you have heard about, like genetic mutations, including BRCA1 and 2. We're going to talk about that again in a second. High breast density seems to be in this bigger risk factor category too, although again, it's not something you can do anything about. If you happen to be somebody who was born with dense breasts, that's how you're put together. They will get a little bit less dense with time, but it's not considered a modifiable risk factor. And then of course, these other factors are having had breast cancer before, having had DCIS, or having had breast cancer in the opposite breast. So most of these big ticket risk factors are not things that we can do very much about. We have to get into the slightly more minor risk factor category before we can start moving things around. Family history is in here. And over here, we're looking at things like hormone replacement therapy, overweight, alcohol, and so on. In the category of risk reduction, we're going to see exercise, childbearing, and breastfeeding. Right? So we always think about risk factors as being either things that we can't do anything about, that we just have to watch, and things that we can do something about. And we're going to dwell a little bit on modifiable risk factors in a minute. First, let's talk about genetics, because again, this is something that's really been in the news. I often hear in my practice, I have a family history of breast cancer. I must have one of those mutations that Angelina Jolie has. This is actually a fairly rare event. Definitely, this is something that you will see. You may know people who have one of these hereditary cancer syndromes. But this is actually a fairly rare event. What are these mutations? What are they doing? Well, this is an inherited problem in DNA repair mechanisms. Back to DNA repair, right? So our cells, again, are equipped with these amazing systems to help our DNA avoid damage. If you happen to get from one of your parents a DNA repair mechanism that isn't working well, then your DNA is more vulnerable and your chances are higher of developing specific types of cancers. There are a bunch of syndromes like this. BRCA1 and 2 are not the only ones. And some of them are also associated with breast cancer. This is probably the most common of the breast cancer-associated genetic mutations, and it's certainly the ones that we hear about the most. So who should be tested for one of these mutations? There's a set of criteria that are set out by the National Comprehensive Cancer Network that tell us who falls into this category. As a rule of thumb, there are generally some red flags. Breast cancers in multiple family members that occur at young ages. Breast and ovarian cancers in the same family. Male breast cancers. Things that really fall outside of the norm. Those are the things that give us a sense that maybe there's something genetic here going on. Most women, even those with a family history, will not have breast cancer risks in the range associated with BRCA mutations. Right? So a BRCA mutation carrier might have an 80% lifetime risk of developing breast cancer. For most women, that number is going to be much, much lower. And we have good tools to help us estimate that risk and start talking about it. We can look at your modifiable and non-modifiable risk factors. We can put them into risk models like this one, which is one of the ones that we use clinically, that includes reproductive risk factors, it includes your family history, your age, and many other things to generate estimates of breast cancer risk in the next 5, 10 years and lifetime risks. So this can help us to really get a better sense of what's going on with any individual person on a statistical level, because we can put you in context with other women who have your same risk factors and also your same protective factors. This helps us to personalize what we're going to do for individual people. So here are the results for Marina's risk assessment. If you take her information and put it all in that big risk model that we were just looking at, here's what comes out. This little graph, the little drawing up here is a representation of her family. You can see her mom and her then in that representation. And here is a graph of her risk. So her lifetime risk is going to be about 29.5% compared to an average woman's, which at her level is going to be about 12%. So this is somebody who is, based on this modeling, is shown to have increased risk of breast cancer. So maybe we're going to want to do something different for her. For women at elevated risk, additional exams and imaging can be very helpful. Women with a lifetime risk over 20% are considered to be at high risk. Again, average is 12%. And there are some things that we can do to watch those women more carefully, as well as to even alter their risk. And we can get into their modifiable risk factors. So now we're going to talk a little bit about what she should do. So Marina comes to her doctor's office and says, all right, I had my mammogram. They say it looks normal, but my breasts are dense, so maybe they're missing something. And they tell me that my risk for breast cancer is elevated. What should I do? First of all, Marina is somebody who should have more intensive early detection surveillance. So she's somebody who should not only get an MRI, a mammogram every year, but she should also get a breast MRI every year. That's going to enhance the chance that we're going to pick up a small breast cancer at an early stage. She should get regular clinical examinations. That's the surveillance end. Then we're going to start talking about modifying her modifiable risk factors. What should she be eating? What should she be doing to help reduce her risk? So nutrition studies are notoriously difficult to do, in part because it's really hard to control what people eat. Right? In order to do a really good study, you have to control every aspect of it. And of course, we're all out at restaurants, and sometimes I lose track of how many pieces of bread I've eaten, right? So you have to recognize that those studies are very, very difficult to do. There is some good data. There is a big study called the Women's Intervention Nutrition Study that's going on. The data collection is over, but the studies are still going on, showing that low-fat diets are associated with a decreased risk of breast cancer. There was about a 9% risk in the control group compared to a 12% risk in the other way around, in the intervention group compared to a 12% risk in the control group. So it made a measurable difference in the breast cancer risk in these groups. The diet that particular study is looking at is, again, low in saturated fat. They didn't change any other factors in that diet. It was fairly prescribed, but women weren't given packaged meals. They were basically given dietary guidelines and asked to follow them, and everything was self-reported. The largest risk reduction in that study was for the estrogen-sensitive type of breast cancer, which makes sense because we know about the connection between fat and estrogen. But we were able to make a pretty significant difference in the overall risk between those two groups. Unfortunately, that is it in terms of nutrition advice that we have for you. Right? We would really like to be able to say, this particular food, that particular diet, gluten-free, paleo, whatever, vegan, vegetarian. There's no good data to support any of those particular diets. The bottom line is that we all really know what we should be eating, right? We should be eating whole grains, fruits, vegetables, low-fat protein, minimal saturated fat, and minimal processed sugar. And that's the same advice that you're going to hear from our nutritionists at the Center for Integrative Health and Wellness, that you're going to hear from your primary care doctor's office. Anyone who tells you that chia seed extract is going to save your life, the bottom line is there's no data to support that. A good diet is pretty simple calculation. The other important intervention from the lifestyle standpoint is physical activity. Statistically, this is going to make the biggest difference in breast cancer risk of all of the modifiable risk factors. So if you take one thing away from this talk, it's that physical exercise is probably the most important thing that you can do for your own breast cancer risk. Physical activity is associated with a 3- to 4-fold reduction in the risk of breast cancer recurrence in women who've had a previous diagnosis, which is a huge benefit. And, excuse me. Thank you. The benefits there are associated with the way that study was designed, looking at women who got cardiovascular exercise. So no studies that show that isometric exercise like yoga makes a difference. Not that you should be discouraged from doing that, but that there's no studies that show that makes a difference. This is cardiovascular exercise, keeping your heart rate at 60% of your own maximal heart rate. Maximal heart rate is 220 minus your age, so easy to calculate. You want to keep your heart rate up at a sustained level for at least 150 minutes a week. So it's a pretty simple recipe. And in multiple studies, that's the thing that makes the biggest difference in terms of breast cancer risk. What's going on there? Again, going back to what we talked about, what fatty tissue does to us in terms of inflammation. Exercise makes a huge difference in terms of how our body deals with food, how it deals with insulin, how it deals with inflammation. Our bodies are machines. They are meant to be taken out and driven around. If you leave your car in the garage for 6 months, you can't expect the thing to turn on. So you should really view your body the same way. It's very, very, very important to get out and use it. And if you take a little time to check your heart rate as you're exercising, you'll find that 60% of your maximal heart rate is not a full sprint. This is where you get your heart rate if you're taking a brisk walk going up and down the hills. So marathon running is not required to be able to get this kind of exercise. Couple other things that people have heard about that are modifiable risk factors: vitamin D levels. There is some small amount of data that suggests that low vitamin D levels are associated with both increased primary breast cancer occurrence and increased recurrence. That data is mixed. There are several other studies that did not bear that out, but vitamin D is important for our bone health and is something that's easy to fix. So I do recommend that anybody who's concerned about that have their vitamin D level checked, and if it's low, that you supplement. Not a good idea to stop wearing sunscreen as a way of fixing your vitamin D level. Just go take a supplement. So here's the summary slide. Get to know your own personal risk. Discuss your personal screening strategy with your physician. If you are at increased risk, you may want to do some type of screening or surveillance in addition to mammography. We continue to recommend that you get a screening mammogram every year. Modify your modifiable risk factors: exercise, sensible diet, vitamin D, keeping your alcohol consumption moderate. Of course, be aware of your own breast tissue, and come and let us take a look at any changes that you find. It's been a real pleasure to talk to you today. I'd like to thank the organizers for inviting me and all of you for all the work that you've done. We all have a reason to stay healthy. This is mine. I hope all this has been helpful information, and I'm going to stay and take some questions. So this says, is breast cancer care in Marin the same as in other parts of the state or country? Yes. So first of all, breast cancer care is quite standardized. Because this is such a common disease, there are a lot of national guidelines, a lot of national programs. So in general, the kind of advice and care that you're going to get is going to be fairly standardized around the country. I am very proud of the breast cancer care that's available here in Marin County. I have an amazing team of physicians and staff members that I work with. Actually have our outcomes data on a slide here, which I'm just going to brag and show you. So these are our 5-year outcomes, and I'm just really, I just got this today from from my cancer registrar, and I'm just really proud of this data that shows that stage for stage we're getting better outcomes here at Marin General Hospital than in other parts of the country. NCDB is the National Cancer Database. So we're really proud of the program here. So for women at high risk of breast cancer, what type of doctor should she see? Should she see an obstetrician, a breast specialist? For women who are increased risk, most of the time, routine care through a primary care provider or obstetrician gynecologist who knows you well is a totally appropriate place to go. First, most of your primary care providers are going to be able to send you to see somebody if there's something that's going on, but you can get routine clinical examinations through the care that you normally get. If you find that you have questions about this that your primary care physician doesn't answer or can't answer, then definitely come and see a breast specialist in our program. We'll be happy to work with you on those questions. And then this has another question on it. What are your thoughts on preventive mastectomy for high risk? Risk-reducing mastectomy is a complicated question. And the bottom line is that it's an individual decision that has to be based on an individual person's risk and their risk tolerance. So when we talk about risk tolerance, really that just means how much risk do you feel comfortable living with? And there are some women for whom the idea of an invasive surgery is something they'd really want to avoid, even though they're living with significantly increased risk. I definitely have mutation carriers in my practice who've decided, I don't want to have surgery. I'm going to have surveillance. And that's a totally reasonable thing to do. There are women who have increased risk based on their family history who don't have a detectable genetic mutation who've decided to have risk-reducing surgery. That's also reasonable. So it really comes down to the individual woman's desire to have surgery, not have surgery, and her understanding and tolerance for her own risk. And so this says, I've heard about Marin Cancer Center. Are they the right place to go? And are they connected to you at Marin General? Right. So we are an integrated program at Marin General Hospital. The Marin Cancer Institute and Marin General Hospital were all one entity. We have a really wonderful program that's modeled on and consistent with the best academic programs in the country. We carry a weekly tumor board, and we have the American College of Surgeons Commission on Cancer highest accreditation that's given to community hospitals. So this is a place where you're getting the kind of quality cancer care that you'd be getting at any major academic institution in the country. We run a very robust clinical research program. So again, something that I'm quite proud of. This is a great question. So how does hormone treatment related to fertility impact cancer risk? We would love to know the answer to that question. There is not very good data around this. The reason is that, again, you can't control most of the variables. So you can look and say, okay, like in a case-controlled way, you can say breast cancer cases versus non-breast cancer cases, who's had fertility treatments or not. In those studies, there does not seem to be a difference. But it's not possible to randomize people to have fertility treatments or not. So we don't have very good control of the variables in these studies. People are on all different kinds of drugs and medications. Some people get a little, some people get a lot, some people have a lot of treatment for a long time or a short time. So it can be very difficult to understand how much an individual woman's fertility history impacts her breast cancer risk. We know that delaying childbearing to begin with increases breast cancer risk, so there's probably an association there. Yeah. Oh, yeah. So is the issue about alcohol related to the alcohol itself, or is it related to the associated weight gain and metabolic changes? That's a great question. So we know that alcohol does a couple of specific things in the body that affect the way that we interact with our hormones. Alcohol is metabolized in your liver, so is estrogen, and so is progesterone. And that means that if you're keeping your liver extra busy, it's not necessarily doing its job metabolizing your hormones, and it can increase the amount of circulating estrogen and progesterone that you have. Alcohol also interferes with a protein called sex hormone binding globulin, which binds estrogen and progesterone and keeps it from affecting your cells. So it does have some direct cellular and metabolic effects that promote higher circulating estrogen levels. Do I recommend that women get tested for genetic risk factors? And what does that involve? Yeah. So again, there are some really clear national guidelines about who should have genetic testing. If you meet certain criteria, and those criteria are available online, testing for BRCA criteria, you can see whether you're somebody who would fit into those criteria for testing. We do it here in Marin. I do it actually in my office. Anyone who's going to have genetic testing should sit down and have genetic counseling or a counseling session with a physician who kind of does this a lot and understands what's going on. So that's something that I do a lot. There are, interestingly, a lot of changes in this area because, as some of you may have heard, the BRCA test was on patent until last year, and then that patent was taken all the way up to the Supreme Court and struck down. So now BRCA testing is commercially available in a lot of different forms from a bunch of different labs. Along with that, there have been an explosion of different commercially available breast cancer risk panel tests that purport to test for a bunch of other different possible genetic predispositions that may affect your breast cancer risk. Here's the problem with those tests. We don't understand how to interpret the results. So if you get an abnormal result, we don't know in many cases how much, if or how much that impacts breast cancer risk, because those data are not really available to us. So this is another one of those situations where the cart is a little bit before the horse in terms of what's available. And those big panel genetic tests are something you should be cautious about. And if you're interested in that, you should definitely sit down with a genetic counselor and talk more about it. All right, I mentioned cardiovascular activity as being helpful and preventive. How about weight training? So here's a situation where we don't have data specifically about weight training in terms of the amount that it may prevent breast cancer. We think that the same effects that come into play when you have cardiovascular exercise may cross over, but there's certainly some metabolic effects of getting your heart rate up and keeping it up in a sustained way that are not replicated by isometric exercise. So in general, people should take a mixed approach to exercise. Definitely weight training. Isometric exercises like yoga are important for our overall health, but they don't replace cardiovascular exercise. Okay, last one. I'm allergic to contrast dye. If I can't have a screening MRI, what are my options? This is a great question. So first of all, there are a lot of different contrast dyes that are out there. The contrast that we use for MRI is a completely different chemical than the contrast that we use for CT scans. So if you're iodine or CT dye allergic, you can have a screening MRI. It's a completely different material, and reported rates of anaphylaxis to that material are essentially zero. So it's very, very hard to be allergic to the stuff that we give people for screening MRI. These things do come up, though. There are people who can't get MRIs, in particular those who have metal in their body, plates, pacemakers, aneurysm coils, things like that. So screening ultrasound does work for some of those women as a backup, again, if it's done carefully by the right person. So I'm going to let everybody get up and mill around, and I'm available for questions. Thank you so much.